We are delighted to have with us, or maybe back with us, Dr. Amir Steinberg, who spent the last 10 years of his career here at Mount Sinai as the Director of Quality for the Transplant Program and the Transplant Unit Director, and now is on week 2 as the Clinical Director of Adult Bone Marrow Transplant at Westchester Medical Center, where he joins us today. He's originally from Texas, trained at the University of, college at the University of Texas, and his medical degree from Texas Tech, and then his residency with us up at St. Luke's Roosevelt. We are delighted to have joining us to talk about aggressive lymphomas, Dr. Steinberg.
Hi, everybody. Thank you for having me. It's truly an honor to be, back. But thanks so much. I was looking forward to this talk. And if you have any questions along the way, don't hesitate to shout out. This talk is going to be mainly about aggressive B-cell lymphomas, quote unquote. I had a slide in there, maybe if any questions came up about T cells, but primarily B-cell lymphomas, which make up about 80, B-cell lymphomas make up about 85, close to 90% of all lymphomas. We're going to delve into the history, some of the classification, epidemiology, diagnosis, staging, then focus on primarily 3 lymphomas, mainly diffuse large B-cell lymphoma, and a little bit of primary mediastinal B-cell lymphoma and Burkitt lymphoma, and then just some new therapies that have been approved recently. So in terms of what lymphoma is, or people's concepts of what lymphoma is, I guess the first medical description of it was in 1666. The numbers of the beast, Malpighi publishes what is thought to be like the first recorded description of Hodgkin's disease in a paper on the autopsy of an 18-year-old female. Okay, and in 1832, Thomas Hodgkin published his description on 7 patients who had this unique presentation of what appeared to be a new condition, or a first description of a condition. And he obviously didn't call it, this is Hodgkin lymphoma. But later on, people recognized that what he had described was a unique phenomenon, and that's how it got the name. And years later, they looked at the pathology on some of those lymph nodes. I think 5 out of the 7 lymph nodes that they looked at, they did modern immunostaining on, and they found out that yes, indeed, this would have been diagnosed as Hodgkin's lymphoma. So even just by physical exam and the clinical history and presentation, he was able to unify this as a unique diagnosis. That's pretty remarkable. Now, the history of therapy of lymphomas, primarily it started with radiation therapy, in the early 1900s. And before chemotherapy evolved, starting in the 1940s, that's all they had for Hodgkin lymphoma and for, pretty much for any lymphoma. But Hodgkin lymphoma, they found, responded well to therapy with Hodgkin's, with the radiation. And there was optimism that some patients could indeed be cured with radiation. And so a lot of people in the early 1900s through about the 1950s and through 60s, their main therapy for Hodgkin lymphoma was radiation. For the non-Hodgkins, people quite weren't sure what to give them. I guess they would try radiation, and chemotherapy started to evolve. But that's why we have a separation of Hodgkin's and non-Hodgkin's lymphoma. It evolved from this approach to the therapy. There was Hodgkin's lymphoma that responded well to radiation, acts a unique way, contiguous spread, so you can get a good radiation field on that lymphoma. And then there were the other lymphomas that they lumped up as non-Hodgkin's. And there's different classification systems that evolved over time. Yeah, the Rappaport staging, Kyle system, Lukes and Collins, NCI, real classification. And finally, you have what's called the World Health Organization classification. And they basically break it down. If you open up the World Health Organization textbook, they break it down into 4 main categories for lymphomas: precursor lymphoid neoplasms, mature B-cell neoplasms, which we'll mainly focus on, and then mature T-cell and NK cell neoplasms, the T-cell lymphomas. And Hodgkin's is still in its own category, although someday some people have said maybe it'll be lumped into the B-cell neoplasms, because technically it really is a B-cell malignancy, Hodgkin lymphoma. So this is kind of just the breakdown, and you can see Hodgkin's on Hodgkin's. This is a simplified way that I describe things to patients, or even when I give lectures, and this is how I think about it. You know, I'm not going to pull out a World Health Organization textbook to a patient and say, page 66 is what you have. I kind of break it down like this. And in terms of the behavior, you could see how aggressive the lymphomas might be. Good, meaning like not as aggressive, or low grade, bad, and then ugly. And this analogy comes from a physician, Dr. Miller. I heard him speak at a conference one time, a lymphoma specialist in Arizona, and he got this good, bad, and ugly characterization of the lymphomas. And we're going to focus more on what he would have characterized as the aggressive and highly aggressive lymphomas. This is just one of the famous Clint Eastwood movie. I'm not going to whistle the famous tune for you, but there were about 3 of these movies, The Man with No Name, and this was the culmination of that trilogy. Now lymphomas, they're not uncommon. Maybe there's 40 to 50,000 diagnosed per year, maybe more, approaching 60,000. And you could see here, they make up about maybe the 5th most common kind of cancer in humans. So, and you could see that it is increasing in age. Based on your age, you have a higher risk of getting these lymphomas. Especially you see here diffuse large B-cell lymphoma, the most common lymphoma. And the incidence overall is rising. And yet, fortunately, the mortality is decreasing because of all the great therapies we have now. Incidence is rising, some people think, because we have a lot of immunocompromised people now, whether it's from HIV or other immunosuppressants people take for other conditions. It weakens your immune system and puts you at increased risk of lymphomas. And additionally, there may be also an environmental factor involved, carcinogens and toxins in the environment that have increased the risk as well of getting lymphomas, because other cancers a lot of cancers are decreasing incidence. So those are a couple of the thoughts behind why it's going up in incidence. Now, when I have a patient who has lymphadenopathy, or if any of you have a patient with lymphadenopathy as internists, you don't obviously right away assume that it's a lymphoma. It could be just, you have to tease out the symptoms. Or do they have some acute infection that's causing them to have the swollen glands? But if you can't seem to tease it out, and if, let's say, 2 or 3 weeks go by and you can't figure it out, then it's time to, really kind of pursue things about, biopsy. And what kind of a biopsy are you going to get? Well, the motto I learned is the tissue is the issue, or no meat, no treat. All right, so you gotta get that tissue to really make a diagnosis, and then treat them. Now, what do? Do you get an FNA? Do you get a core needle biopsy, or do you get an excisional biopsy? So I'll have a lot of patients refer to me, let's say, when they've had an FNA. Let's say they've gone to an ear, nose, and throat doctor first. And an FNA, a fine needle aspiration, might be fine for someone, let's say, who's got maybe a head and neck cancer, squamous cell, or, adenocarcinoma. That might be enough. But for lymphoma, you need more of the architecture to really make a diagnosis, or a specific kind of lymphoma, right? Because there's tons of them. So you got to really, you want to get more tissue. And here's just one example that 93 FNA attempts at initial diagnosis just of lymphadenopathy, only 27 were given a specific and complete histological diagnosis based on, the World Health Organization categorization. So FNA is really not the answer. You really want to get more tissue. And so, if you can at least get a core needle biopsy, which is just a larger needle. All right, so you get a core needle, might be satisfactory. And then the gold standard is an excisional biopsy, actually taking out part of that lymph node. And just as like a little history from me, I was diagnosed with Hodgkin lymphoma as a 17-year-old senior in high school. And I remember they first did an FNA on me, a pathologist, and then they weren't quite sure, or yes, it made them suspect. And then they ended up sending me for an excisional biopsy. So ultimately, you needed that 100% confirmation. Now, the lymphomas we're going to talk about, especially diffuse large B-cell lymphoma, have different cells of origin. This is like, let's say this is the lymph node. You see the marginal zone, the mandal zone, and the germinal center of the lymph node. And for example, their primary mediastinal B-cell lymphoma or ABC type diffuse large B-cell lymphoma derives from this pathway. Germinal center diffuse large B-cell lymphoma you see derives from there. Other lymphomas like MALT lymphomas or marginal zone lymphomas come from the marginal zone of the lymph node. So mantle cell lymphoma comes from, let's say, from the mantle zone. So when you diagnose a lymphoma, there's an immunohistochemistry pattern that'll help you diagnose what kind of lymphoma. So these are kind of the more common lymphomas we might see or diagnose, especially of the B-cell variety, as CD20. That's a classic B-cell marker. And you can see there's a bunch of them that are CD20 positive. So you need to stain or do flow cytometry for these other markers to help distinguish what kind of a lymphoma it is. You don't just rely on this, you also need the morphology. And then in addition, you can do other staining to help clinch a diagnosis or support a diagnosis such as BCL6, BCL2, and Ki67, which aren't exclusive to these diagnoses here, but help support it more. Now, once you've, say, diagnosed a lymphoma, you've gotten the biopsy and you've had the pathologist look at it, and you know what they have, now you got to stage them. And again, the staging evolved from Hodgkin lymphoma. And what the staging that came from Hodgkin lymphoma was eventually adopted for all other lymphomas. So these are the various regions of our body where the lymph nodes are found. There's cervical, left or right. There's the left or right axillary. There's a mediastinal, periaortic, mesenteric, and inguinal, left or right inguinal. And these are these were described as the core nodal regions at in a meeting of 1965, Westchester Country Club. I believe that's in Rye. Yeah, Rye. And that's where they first came up with this staging idea for lymphomas, and more specifically for Hodgkin lymphoma. And eventually they developed this, what we now know of as the modern Ann Arbor staging classification, which is used for all the lymphomas. Stage 1 is if it's just one single lymph node. Stage 2 is if it's more than one lymph node region, either above or below the diaphragm. So you can have a left armpit node and a right neck node, but nothing below the diaphragm, that's stage 2. Or a left groin node and a right groin node, and nothing above the diaphragm, and that's stage 2. Once you cross the diaphragm, either from one side or the other, that's stage 3. And then stage 4 is if it leaves the lymph nodes. Let's say it's in the bone marrow, it's in the brain, the pleural fluid, that's stage 4. So mainly we'll talk about diffuse large B-cell lymphoma. And initially, they didn't know how to distinguish different variants of diffuse large B-cell lymphoma. They tried to do it morphologically. You could see these different morphological variants, centroblastic, polymorphic, immunoblastic, though the outcome didn't vary amongst them. So they tried to figure out ways that they could improve their prognostic categorization of the lymphomas. And so these are different ways that we've been able to categorize the prognosis of the lymphomas. There's the IPI score. We've developed gene expression profiling, the Hans algorithm, and then expression of MYC, BCL2, and BCL6. So the IPI, also apples, if you really want to memorize it. So age, performance status, LDH, extranodal sites, and stage. And so when I have a new patient with diffuse large B-cell lymphoma, I can sit down with them and I can basically tell them their prognosis, their survival based on what features they have. Now there's a more up-to-date one, which we'll get to later on in the PowerPoint presentation, but the numbers are better. So the numbers are better than what you see here. But nonetheless, that's one reason why I like to treat lymphomas, especially diffuse large B-cell lymphomas amongst other cancers, because it tends to have a better prognosis. You can even potentially cure the stage 4s, where it's hard to cure really stage 4 of other cancers, but for diffuse large B-cell, we can cure them. So then they had gene expression profiling that began to develop that could help distinguish the lymphomas and their prognosis. And you could see here, based on the profile, the gene expression profile is a famous paper from 2002. They were able to determine that there is a germinal center B-like lymphoma, diffuse large B-cell lymphoma, GCB. And then there's non-GCBs, which include the activated B-cell and the type 3. And you can see the germinal center B-cell lymphoma, diffuse large B-cell lymphomas just did better. The problem is that gene expression studies, they require fresh biopsy material or biopsy material that's frozen immediately after excision. That's logistically difficult. And so they weren't able to really get this kind of like in real time or in real practice. So what alternative could they come up with? There was something that was developed called the Hans algorithm. And there's not a guy named Hans. It's actually, my understanding, a woman with the last name Hans. So it's not like Hans and Franz and, but you could see here that Dr. Hans came up with, and colleagues came up with this algorithm, and it's based on CD10, one of the clusters of differentiation found on lymphoma. And if it was CD10 positive, boom, they were a germinal center B lymphoma, which generally a better prognosis. If they were not CD10 positive, they could still end up as a GCB, but they had to do these other stainings. So that using these other immunohistochemical stainings, we were able to categorize our lymphomas into GCB or non-GCB. And that helps prognostically. I don't know yet if it helps us therapeutically. Might make us think, well, somebody, maybe you need to be more aggressive with them. But at least when you sit down with a patient, it can kind of further help you define for them like their chances. And using further staining and further testing using BCL2, BCL6, and MYC, the World Health Organization is able to categorize some of these conditions, which we define as aggressive B-cell lymphomas or just diffuse large B-cell lymphoma. Now there's maybe something more specific about them. For example, diffuse large B-cell lymphoma, it can express these other features that we call these other mutations or mutational profiles that include MYC or BCL2 or even BCL6. Burkitt lymphoma would only have the MYC mutation. There's a type of lymphoma called blastoid lymphoma, large B-cell lymphoma, which is kind of like a B-cell ALL, like a acute lymphoblastic leukemia, but with, say, more lymphoid features, and that expresses TDT. In its immunohistochemical staining. So that also helps us further differentiate the lymphomas. You may have heard of something called double hit lymphoma. That's a type of high-grade B-cell lymphoma, and it has a dual arrangement of MYC and BCL2 and or the BCL6 genes, a rearrangement. And when all three of them have rearrangements in the genetic profile, that's called a triple hit lymphoma. There is something else called double expressor lymphoma, which it's not a gene rearrangement, but when you, stain the cell for BCL6 or BCL2 or MYC, it does express. And you can see here, it's technically not a double hit lymphoma, and it makes up a greater percentage of those diffuse large B-cell lymphomas, those that just express these proteins, but don't actually have a molecular abnormality associated with them. So putting that all together, I know this is confusing. This is like, what is he talking about, right? So this is just to summarize things. 1/3 of diffuse large B-cell lymphomas are positive for MYC and BCL2 by immunohistochemistry, not by mutational testing. And we call those double expressor lymphomas, diffuse large B-cell lymphomas. And most of them are the ABC type. That type that you saw in the gene expression profiling in that 2002 New England paper. And the new World Health Organization category of a high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangements, double hit, usually but not always falls into this double expressor. So some of these double expressors not only express the protein just on the surface alone, but actually have a molecular abnormality. And that's why you have that overlap. And some of them will fall into this GCB category. So even the good risk, what will look like a good risk features on gene profiling from that 2002 New England Journal paper, some of them are actually double hit, which you think of sometimes as bad. So bottom line is we're still learning. All right, that's the take home. And here you could just see, just to kind of further categorize it, Burkitt lymphomas have that MYC rearrangement. That's positive Burkitt's right there. If they look like Burkitt's under the microscope, you don't just base things morphologically, but let's say they don't express the MYC gene rearrangement, but they look like Burkitt's under a microscope, then you would just call it a high-grade B-cell lymphoma or diffuse large B-cell lymphoma under the microscope. I mean, based on the microscopic findings. So that's kind of how these things are helpful. Now, will it vary how you treat them? A little bit, especially when we get to how you treat Burkitt's lymphoma specifically. So we'll get to that. So we're still learning. We're still trying to categorize lymphomas and how to take that categorization and treat and learn how to treat them. So how should diffuse large B-cell be treated? So Goodman and Gilman, they were working with the Army, actually in military grants. They were the first ones to develop chemotherapy, what we think of as chemotherapy. Not going back to syphilis chemotherapies, so to speak, but for cancer. Based on what their development of mustard or mustargin for Hodgkin lymphoma, DeVita and colleagues at the NIH, that's Dr. DeVita, and that was Goodman and Gilman there, they developed a regimen called MOP for Hodgkin lymphoma, the mustard or meclorethamine, oncovin, procarbazine, and prednisone. So, alkylating agent, and so combination chemos to help with lymphomas. And ultimately, what they did was they developed a regimen called CHOP. And CHOP, which is our bread and butter therapy for a lot of lymphomas, stands for cyclophosphamide, hydroxydoxorubicin, or adriamycin, or doxorubicin. So it's kind of confusing because nobody calls it hydroxydoxorubicin, but that's how the H comes into play. We all call it either adriamycin or doxorubicin. So that's confusing. And the other confusing thing is no one ever calls vincristine oncovin. I guess that's the brand name. So keep that in mind. It's really just cyclophosphamide, doxorubicin, vincristine, and prednisone. And you can see here, they compared CHOP to various other regimens that were available at that time. And this was a famous study from 1993. And you can see they all had about the same overall survival, but CHOP was considered less toxic. And that's how CHOP won the race. So CHOP became the best. And that's how we've used CHOP as our basis for all further therapies, because it was less toxic than some of the other ones. Now, rituximab then developed in the 1990s, and rituximab is a monoclonal antibody that targets CD20. And so nowadays we use R-CHOP as like our main bread and butter therapy for diffuse large B-cell lymphoma. And you can see that CHOP plus rituximab versus CHOP alone, the CHOP plus rituximab, or R-CHOP, won out. That was in 2002, and that kind of time when it started to become just the standard of care for diffuse large B-cell lymphomas. And I mentioned the prognosis to you before, the IPI. There's an IPI score in the Age of Rituximab. And you could see here, they use the same prognostic features that we talked about before, apples, but now the prognosis is a lot better. So you can sit down with that patient, even those who have 3 or more of the apples features, age, performance status, LDH, extranodal sites, or stage, they still have a progression-free survival, which I would consider kind of like a remission for the most part. Most of those are remission or possibly cure at 53%. So half the patients might be cured 3 years out, which is great. Could obviously we want it better, but it's better than 50% chance that you're going to be okay in the future. There's a movement that's happened, let's say, for example, in breast cancer for dose-dense therapy, meaning giving it, therapies more frequently. And they tried this approach. CHOP is given every 3 weeks, as in a one-day infusion in the infusion center, and in a group tried giving it every 2 weeks. And you could see here that overall, the every 2-week group seemed to do better. You could see much better overall. There you go, overall survival, and that's the progression-free survival. So why didn't this take off, or hasn't this been adopted? Why do we still use the every 3-week regimen? Further studies have shown that this benefit was thought to be kind of eliminated, so to speak, with the introduction of rituximab. So that's kind of why we're still at the R-CHOP every 3 weeks. I wanted to tell you a little bit about a lymphoma that can resemble diffuse large B-cell lymphoma. It's called primary mediastinal B-cell lymphoma. And it arises in the mediastinum from thymic tissue, this area in our chest right here. And more females tend to get it. But because of this bulky nature in the chest, a lot of patients might present with SVC syndrome or superior vena cava syndrome, and they might have swelling in their face and in their neck and in their arm. Now, it's very important to distinguish this from Hodgkin lymphoma, because even this is a B-cell lymphoma, but it can express CD30, and both Hodgkin lymphoma and primary mediastinal B-cell lymphoma also can express CD30, which is found on a lot of T-cell lymphomas. So you have to really be careful that you have this diagnosis. And what's interesting is that unlike other what we call diffuse large B-cell lymphomas, that's why they think this is a distinct entity, even though it might look like it morphologically, is that it expresses a lot of PD-L1 and PD-L2. And that comes into play with the new therapies that we have nowadays called checkpoint inhibitors, and nivolumab, pembrolizumab, Keytruda, Opdivo, medications that we hear about that are very famous for treating folks like Jimmy Carter for his melanoma, or treating folks for lung cancer. It's actually been FDA approved also to treat relapsed or refractory primary mediastinal B-cell lymphoma, because they express a lot of PD-L1, PD-L2. But you can see here how the condition can resemble Hodgkin lymphoma with the CD30 expression. So here, primary mediastinal, nodular sclerosis, Hodgkin's, the most common kind of Hodgkin's right there. But CD20, notice, is much more prominent. That's the classic B-cell marker. And even though we mentioned Hodgkin lymphoma might be a B-cell lymphoma, it doesn't really express much CD20. So that helps you make that distinction. And what helps you make that distinction from the more common distinct entity of diffuse large B-cell lymphoma is that CD30 expression, which you don't really see so much of in diffuse large B-cell lymphoma. And here you just have that PD-L1, 63% of patients express or have that gene for PD-L1, PD-L2. That's why it responds well to these checkpoint inhibitors. There's another regimen, and we call it dose-adjusted R-epoch. And dose-adjusted R-epoch, you can see it looks similar to CHOP, and it is. It's got 4 of the same ingredients as CHOP: the C, cyclophosphamide, the H, doxorubicin, the O, vincristine or oncovin, and the P, prednisone, but they add etoposide. And they also give this over the course of 4 days. And with each cycle, it's an infusion. You get an infusion, a continuous infusion, basically every day for 4 days. And you go up on the dose with every cycle. And so at cycle 6, if you've tolerated each subsequent cycle, you're at a maximal dose. So it kind of gradually builds up the dose. The body kind of gets used to this ramp up. And you can see that for primary mediastinal B-cell lymphoma, look at the cure rates. It's remarkable. I mean, it's like almost off the charts. So that's the standard of care for primary mediastinal B-cell lymphoma is dose-adjusted R-epoch. We don't give R-CHOP for primary mediastinal B-cell lymphoma, that distinct entity, that we mentioned. And so because of these excellent results, some people obviously think, well, can we give this for diffuse large B-cell lymphoma? Maybe more chemo, gradually increasing the dose, maybe that'll help the diffuse large B-cell lymphomas as well. So glad you asked. There was a trial. It was a randomized trial, multi-center, and they enrolled, 230 patients or a little bit above in each arm, compared R-CHOP to dose-adjusted R-epoch. And the bottom line is, bottom line, let's just see, the event-free survival, which is, basically, recurrence or progression, was the same in both arms. There wasn't much difference. The overall survival was the same. Event-free survival was the same between R-CHOP and dose-adjusted R-EPOCH. That being said, we still use dose-adjusted R-EPOCH on occasion for diffuse large B-cell lymphomas. The authors did note that they had a lower incidence of double expressor phenotype compared with the literature. And they suggest that the study population likely reflected a more favorable patient population. And think about that. If you have a patient maybe who's got a really bad lymphoma, they're not going to like sit around and wait around for a trial. They're just, let's just start me on a therapy. Or they may be too ill to enroll. Their performance status might be worse. And so there might have been possibly some selection bias in this study that the authors make note of, that maybe it wasn't a true reflection of our patient populations. And just based on phase 2 results that seem to show benefit to dose-adjusted R-EPOCH, not this particular study, the authors say that you should not discourage the use of diffuse large B-cell lymphoma in certain settings. What are those settings? I might give it to someone maybe who's younger, who I think can tolerate the higher doses. I might give it possibly to someone maybe who's got the double hit or triple hit, or maybe those double expressor lymphomas, just because in general they have a poor prognosis, or a non-GCB based on that gene expression profile or the HANS classification. I might give that regimen to those particular patients, case by case basis. So as a general outline, how do we treat the diffuse large B-cell lymphomas? The most common type of lymphoma, you give them R-CHOP or dose-adjusted R-EPOCH, and if they go into remission, fantastic. Maybe they're cured. 53% will hopefully be cured if they, even with the worst prognostic features. If they do have a recurrence or they don't go into remission, then you give them what's salvage regimens, of which there are a ton of. And if they then respond to the salvage regimens, they then go to an autologous transplant, which is basically a way to give high-dose chemo. It's called high-dose chemo with stem cell rescue. And if they relapse after that, what we have available now is CAR T-cell therapy, which we'll briefly touch upon. Also in the equation is an allogeneic transplant, which is a transplant using another person's stem cells to elicit a graft versus lymphoma effect. And we have clinical trials here and there that you can enroll a patient in. But there is a CAR T trial that has closed, and we're waiting on the results on, which compared autologous transplant to CAR T cell therapy in this setting, the relapsed refractory diffuse large B-cell, their first relapse. And we'll see what happens, what those results show. It'll be interesting. But this is what happens with a transplant. Let's say you get the R-CHOP and then you have a first complete remission, awesome. But then you relapse or you're refractory. You then have to rebiopsy. Always have to rebiopsy. The tissue is the issue, because sometimes the lymphomas can transform. And sometimes you can have a false positive on a PET scan. So you gotta biopsy, okay? You give them that salvage therapy we talked about, and then you collect their stem cells and they get high-dose chemo. That's what this is, high-dose chemotherapy that otherwise would kill the lymphoma, but would otherwise also kill all your blood counts. They would never recover. But because you've collected someone's stem cells ahead of time, you just reinfuse them after that high-dose chemo and their blood counts recover. That's just what a autologous transplant is. It's high-dose chemo with stem cell rescue. That's all it is. And you could see here, it became the standard of care for relapsed refractory diffuse large B-cell lymphoma in 1995. You could see just patients that just continued standard conventional salvage chemo, their event-free survival, or in essence cure, long-term remission, was a lot lower than those who then proceeded to transplant. That's how, so transplant's a standard of care for relapsed refractory diffuse large B-cell lymphoma. And here's just the overall survival is higher because of great salvage regimens when they do relapse. And there's long-term data we have in a registry called the CIBMTR. It's for Center for International Bone Marrow Transplant Research. We all submit our data to them as transplant centers, and they keep a gigantic database. You could see that a lot of transplant survivors continue to live long-term. So it's a really great therapy. It sounds scary, but if we can get you through it and get you better long-term. And the mortality of that, even though we can cure a lot of folks, the mortality, that's about 5%. This is better data now, better supportive care, but about 5. So out of 100 patients who get the transplant, 5 of them die from transplant-related complications, and then the 95% survive the transplant itself, and maybe half of those might be cured. And then the other half, they relapse, and you do some other kind of therapy for them. So moving on to another kind of aggressive lymphoma, Burkitt lymphoma. I was reading like an essay recently from one of my, I guess a mentor of mine. He was a pathologist at Mount Sinai for quite some time. He mentioned that there was a shift, I guess, and then maybe it was in the 90s. They went from, say, Burkitt's lymphoma more to Burkitt lymphoma, or Hodgkin's lymphoma to Hodgkin, because like the Burkitt and Hodgkin didn't actually have the disease themselves. It's kind of like something that pathologists started to, you can call it Burkitt's or Burkitt lymphoma. This is Dr. Burkitt, and this is Epstein, virologist Dr. Epstein. And Dr. Burkitt described a disease he'd seen in Africa in 1958 in the British Journal of Surgery under the title "A Sarcoma Involving the Jaws in African Children." And he was working with tissues samples provided by Burkitt, Dr. Epstein, I guess Dr. Barr, Epstein-Barr. Anyways, they discovered that there is a virus associated with Burkitt lymphoma. So most Burkitt lymphomas are associated with Epstein-Barr virus. And it's one of the fastest growing tumors. They say it's got the fastest growing, they say, and it's got a doubling time of 24 hours. So it's fast growing, and you must act quickly. You must treat aggressively. The more endemic form, let's say in Africa, occurs as a jaw mass, and the more sporadic forms in the US, Europe may oftentimes present as an abdominal mass. And you have to give them central nervous system prophylaxis because they can hide as a sanctuary site in the CNS. It's just jam-packed with cells. And they sometimes call it a starry night appearance, starry sky appearance, because it's just how jam-packed the cells are with, just the cancer cell constantly growing. And it's associated with translocations in chromosome, the 814 translocation is the most famous one out of them, and the c-Myc oncogene, gene rearrangement. And going back to the University of Arizona professor, Dr. Miller, who characterized the lymphomas, let's say, as the good, the bad, and the ugly. The Burkitt lymphoma, he characterizes one of the ugly ones, just because how aggressive it is, doubling time, and how scary it is. And we're concerned about tumor lysis. But you can also kind of think about it philosophically. Is it ugly? This is just the Leprechaun. I don't know if anyone ever saw this movie. I happened to catch it one night, like on Sci-Fi Network. It just starred Jennifer Aniston, believe it or not. But it was a bad, bad movie. And then Ugly Doll is more popular nowadays. All right. I guess you guys are snickering on mute. But you could see here, regimens for Burkitt lymphoma. Look at the survival. Look at the event-free survival here. 90, 89, 80, 69. These are much better than diffuse large B-cell lymphoma. So you could make an argument that the cure for Burkitt's is much, much higher than any other lymphoma. And certainly part of that is because of the aggressiveness of the lymphoma, how much it replicates, almost kind of the way I think about it, that chemo cell can intercalate itself, can get inside of those dividing cells and help kill the cancer better. Whereas with the low-grade lymphoma, it's not as much. So whereas a person may not die right off the bat from a low-grade lymphoma, they're living with it for a long time, and it sometimes may never be cured. Whereas these fast-growing lymphomas are potentially curable. So you can argue philosophically, is this ugly or is it good? What would you rather have? The fast-growing lymphoma, or to live with a low-grade lymphoma and to live with it? Yeah. So some regimens they've used for Burkitt: Codox-M, R-EPOC, Hyper-CVAD. Maybe you've heard of Hyper-CVAD. Our dose-adjusted R-EPOC is the one that's kind of becoming more common and popular. Here's like one study that actually I believe Mount Sinai was involved in, where they tried to risk stratify how much chemo a patient needed who had a newly diagnosed Burkitt lymphoma. And whether they needed, say, 6 cycles of dose-adjusted R-EPOC or just 3. So there were really good results about that. Now, just some other aggressive lymphomas I really won't go into, but plasmablastic lymphoma, very bad lymphoma. It's very rare that I've seen a long-term survivor, and these are oftentimes associated with HIV. primary effusion lymphoma. As you can imagine, they'll oftentimes present with pleural effusion involvement. Interestingly, they respond to daratumumab, which is a CD30 antibody approved for multiple myeloma. And then just some Castleman's disease. It's a large cell lymphoma arising from Castleman's disease, I should say, which tends to behave more aggressively. T cell, histiocyte-rich large B-cell lymphomas, and Epstein-Barr virus diffuse large B-cell lymphomas of the elderly. And they just in general, they don't respond as well to the R-CHOPs or dose-adjusted R-EPOCs of the world. You know, T-cell lymphomas in general, like just don't do as well. And that will oftentimes even just transplant them up front. I know I'm focusing more on the B-cell lymphomas, but the T-cells, just as an aside, we're constantly working on ways to improve therapy for them. And here's just, for example, just one as a side, pique your interest. Since we don't have rituximab for T-cell lymphoma, since they don't express CD20, you know, they did a study comparing CHOP to CHIP. You know, they took out the vincristine and they added brentuximab, which is a CD30 antibody, kind of like a rituximab for T-cell lymphomas. And you can see that there were better outcomes in progression-free survival by swapping out. The reason they swapped it is because both brentuximab and oncovin or vincristine can cause peripheral neuropathy. All right, so they didn't want to double down on that side effect. Lastly, I just want to talk about new therapies. The first one I want to talk about is CAR T therapy, chimeric antigen receptor therapy. The first one approved was Yescarta, axibitidine psilocybin, right? Yeah, I would just call it Yescarta. That's the brand name for it, you know, but it was approved October 17, 2017 in adults with large B-cell lymphoma who had basically gotten 2 other kinds of treatments and had failed. So it's basically a patient who got diffuse large B-cell lymphoma, got R-CHOP, then had a transplant and they relapsed after the transplant, or a patient that just didn't respond after relapsing from the R-CHOP or responded to the R-CHOP, they then got a salvage therapy and didn't respond to that either to even get to the point where they'd be transplant eligible. So very sick population, very refractory population. Now what happens with CAR T cells? Instead of taking stem cells out of the body and then rescuing somebody with an autologous stem cell transplant, just high dose chemo, instead what you're doing is you're taking out the T cells from their blood and you're teaching them and training them to attack B cells. So you're teaching them to attack another B cell marker, CD19. You're using the patient's own immune system and reinfusing that immune system into somebody. It takes about 3 weeks to train the cells in a laboratory to attack their B cells, the T cells to attack the B cells, and then you ship them back and then you give them to the patient. And here's just the study that this approval was basically based on. They took 111 patients based on, I believe it was a phase 1 study. Can you believe that? Like the FDA approved it based on just the results from phase 1 data. And you could just see a lot of these patients were very ill. 77% were resistant to second-line therapy, 85% were advanced stage, and the response rate was 82%, and a complete response, meaning the lymphoma had gone away, was 54%, over half the patients. And check this out. The progression-free survival 2 years out was 40%. That means like the cancer hadn't progressed. Basically, a lot of the patients were cured in remission over 2 years out. That's remarkable. And then overall survival slightly higher because of salvage therapy. So based on this data and phase 1 results, they approved Yescarta from Kite, company Kite, I believe they're, yeah. And then the other, the side effects you got to worry about include cytokine release syndrome, because when you reinfuse those T cells into the patient, there's just a huge cytokine storm going on where those cells are starting to replicate and attack the lymphoma. So it could be a very serious thing. And we've developed ways to mitigate that risk using a medication called tocilizumab that targets IL-6 and dampens down that IL-6 response. And also neurologic toxicity. And we give steroids for that, where patients can become encephalopathic. In May 2018, Kymriah was approved, no relation to Kardashian, but I can't hear people laughing in the Zoom, but all right. Kim Raya, okay, was approved May 1st, 2018. All right, so now there's a competing CAR T, and then Mount Sinai was in the process of getting this approved as well. And the advantage of this one, some say, is that it could potentially be given outpatient. A little bit more predictable cytokine release syndromes, toxicity, and then you just readmit them if they do develop those symptoms. Again, Mount Sinai was involved with a randomized study that I alluded to, comparing CAR T to diffuse large to autologous transplant. And we'll see what those results end up showing. 3 other therapies that were briefly, I'll give one slide on each, that were approved were polatuzumab, selinexor, and tafasitamab. Polatuzumab is a CD79 antibody, 79B antibody, antibody-drug conjugate, actually, kind of like brentuximab. Brentuximab is actually a CD30 antibody-drug conjugate. And we sometimes will use this as a salvage, let's say, if they failed an autologous transplant and maybe to bridge them to CAR T, or if a patient's not fit for a transplant, this might be a good option. It's got a very good long-term CR rate as well. 40% of patients had a CR, after the therapy, and a lot of those CRs were actually pretty durable. I have not used selinexor for lymphoma. I've covered some patients who have gotten selinexor for myeloma. So it was also FDA approved recently. It's another option for patients, let's say, who are quite relapsed and refractory. It's an oral drug. So whereas the polatuzumab is IV, it's an IV infusion. The advantage of the selinexor is oral. And then finally, just the last one, which I have used as well. We call it Monjuvi, but the generic is tafasitamab. And it's a CD19 directed cytolytic antibody, and it's used with lenalidomide or Revlimid, a pill we take for, it's approved for certain lymphomas, and now it's approved in conjunction with this drug for diffuse large B-cell lymphoma. And it's very well tolerated. I've had patients who've had this for relapsed refractory lymphoma, even after CAR T. And it's just a well tolerated drug. So that's a whirlwind tour of aggressive lymphomas, specifically the aggressive B-cell lymphomas. And if you have any questions, I'm happy to stay and answer them. And again, thank you so much for having me.
Wow. That was a lot. You covered a lot. Thank you for that.
Sure.
We'll open the floor for questions, either to put them in the chat, or I'll let people unmute and ask their own questions. Dr. Miller has a comment on T-cell. I don't know if you want to unmute yourself and ask that, or you're asking for Dr. Steinberg to comment on it.
Yes.
Let me check. What? Let me check out the chat. All right. Comment on T-cell. Well, the T-cell lymphomas, they make up about, I would say, 10% of the lymphomas total, and there's a slew of them as well. I guess the more common ones we think of are T-cell lymphoma not otherwise specified, angioimmunoblastic T-cell lymphoma, and then the ALK positive and negative T-cell lymphomas. And again, they don't respond as well to therapies. You could still potentially cure them. And I don't think it's just because we don't have, say, true rituximab for T-cell lymphomas. It's just they're more, for whatever reason, more aggressive, resistant. They are working on, trials for even CAR T to target them. They're working on different, drugs to target T-cell lymphoma. And there's about 3 or 4 that are approved by the FDA, but it's frustrating sometimes to treat them. That's why we'll be more aggressive to them up front. For tissue is the issue. Oftentimes we're giving differing opinions on FNA versus taking out the lymph node. What do you prefer? Again, I would prefer, I guess, the lymph node to be taken out to get a definitive diagnosis. I'll never rest my laurels on an FNA unless, for whatever reason, there's just no other way to access. Let's say it was like really deep in the body, and it would involve, let's say, a video assisted thoracic surgery, or VATS or something. And that would be the only way. And, patients say declining, then I might go with an FNA. But truly, like if you really wanted to know and to treat them better, you want to get a better tissue, because you see here, there's some differences even in the B-cell lymphomas and how we treat them. And the T-cell lymphomas, there's some subtleties that will help us in our decision-making and management. So always prefer, if you can, get a core biopsy if you can. But excisional is always the best. I still have the scar here. I mentioned at the beginning of my talk that I had Hodgkin lymphoma, and I still have the scar here. It's a war story I can share with folks about how I had first an FNA and then an excisional. But excisional was the right call, to be 100% sure. As you saw, there were some differentials even with Hodgkin lymphoma on what it could be.
Dr.
Great
Steinberg,
questions.
Steinberg, can you hear me?
Yes.
This is Shamit Patel, one of the hospitalists. I have a question regarding like autologous bone marrow transplants versus allogeneic. And is the autologous more likely to fail because you're retransplanting the lymphoma back into the patient potentially?
That's a great question. So they really haven't been compared so much head to head. So it's tough to say which one per se is better. But I would say if you're talking about the efficacy, an allogeneic would be more efficacious because it not only have, let's say, a high dose chemotherapy aspect that kills the lymphoma, but then you kind of rescue them using another person's immune system, which will recover your counts, but also then attack the lymphoma. And the problem with that is that you could develop graft versus host disease, which can affect, maybe I would say, I usually quote 40% of patients would have clinically significant graft versus host disease. And they have to have immunosuppressants to prevent that and get infections because of that. So the mortality is a lot higher with an allogeneic transplant, let's say 15 to 20%, whereas with an autologous, it's 5% or lower. Now, you mentioned a great point about whether those cells you're introducing back into folks are contaminated. And that's why we want to get a good response on salvage. When they get, say, relapse after R-CHOP and you give them some new combination, you want them to respond well, because when then you collect their stem cells, you don't want to be collecting cells, in that stem cell bag, those CD34 stem cells. You don't want to also be collecting lymphoma in them, because then you'd be theoretically giving them back. Now, for whatever reason, even though that theoretical risk does exist, we are able to get a long-term complete response in 40 to 50% of our autologous transplant patients, even with that theoretical risk. And I think maybe there's some other factors involved. Even if you were to reintroduce a lymphoma cell into the body, there's other factors involved, I think, that might not automatically cause that one lymphoma cell to start to propagate. But you bring up a good point. That's why we want to have a good response to collect them. And also before the collection, we want to make sure that they never had any lymphoma in the bone marrow, because that's where ultimately those stem cells are coming from. So if they had a clean bone marrow to start with, that's fine. But if they've never got a bone marrow biopsy on them, you want to get one before stem cell collection. Great question.
Other questions? Thoughts?
Okay.
Nothing. I think you answered everything, and you got us out at 5 of. I really appreciate it.
No, thanks. It was fun. Thanks so much. It's a topic I'm passionate about. And again, thank you everybody for listening. And I appreciate it so much for having me.
Don't forget about us, even though you're no longer a.
Absolutely. Have me back again. I'd love to give another talk. So thanks again.
Sounds good. Thanks, Dr. Steinberg. Take care.
Thanks.